understand that the basic anatomy of this region all residents do know and they are aware of. So this would be basically a quick revision. Some of the components of anatomy in this region, which are specially pertaining to the endoscopic view, especially like mucosal folds, uh, uh, are beyond the scope of normal anatomy. So I've just tried to, you know, pool resources and include them, and to explain those in the best possible and lucid manner in the short time period. So let us start. So we'll be talking about the mastoid process, mastoid air cell systems, and the antrum and the adjoining areas, and then we'll be moving on to the mucosal folds. So let us initially uh, recollect the anatomy of temporal bone, and here we have the temporal bone, and anatomically we describe it as having 5 parts, which include a flat squamous portion, a zygomatic portion which completes the part of zygomatic arch, a mastoid part which is seen over here, and a tympanic part which forms the anterior-inferior portion of external auditory canal. And the major part of the temporal bone, or the most important part of the temporal bone, is the petrous temporal, which can be seen from the cranial cavity. And here we are seeing the petrous temporal bone. And here we have the anterior surface of petrous temporal, surface of petrous temporal. Just to orient ourselves, the cursor as of now is on foramen lacerum. Just anterior to it is foramen ovale, and just posterolateral to it is foramen spinosum. This flattened area just lateral to the foramen lacerum is impression for trigeminal ganglion. And as we move laterally, uh, there's a bulging over there, eminence over there called arcuate eminence, which is formed by superior semicircular canal. And if we move lateral to it, there's a flat slopy bone which is called tegmen tympani. We all know that this tegmen tympani forms the roof of middle ear cavity. If we see the posterior aspect of the petrous temporal bone, two major things to note here. This is a impression for sigmoid sinus. That means the sigmoid sinus is in close proximity of the ear. And medially, if we move medially, there's internal acoustic meatus. Okay, so just to orient, sometimes and styloid process is the fifth component of temporal bone, and sometimes it is counted in within the parts of temporal bone. In some books do not mention it. And sometimes petrous and mastoid parts are together called as petromastoid. These are the two most important portions because they house the whole of the ear apparatus. So from ENT purposes, this petromastoid part is the most important part for us. Mastoid process, a very palpable bulbous expansion just posterior inferior to the external auditory meatus, and it is not present at birth, and it starts developing by the end of first year. The implication being that the stylomastoid foramen, which lies because the styloid process lies just anterior to the mastoid process, enteromedial to the mastoid process. So there's a foramen called stylomastoid foramen from which the facial nerve exits the cranial cavity. And because of non-development of mastoid process, or less development of mastoid process, the facial nerve is quite superficial and is liable to injury in young children. So within the body of mastoid process, there lies an air-filled cavity called mastoid antrum. And this antrum starts developing at 24 weeks of gestation, and is almost the size of an adult at the birth. And to describe its size, it is a size of a pea, and that means 1 centimeter in diameter, or 1 centimeters across all dimensions approximately, and is in 1 milliliter in capacity. Anteriorly, this mastoid antrum communicates with the epitympanic recess or epitympanum, and superiorly the tegment tympani, which is a thin plate of bone, overlaps it. Naturally, just superior to it lies the cranial cavity and the temporal lobe of the brain. Posteriorly, a thin plate of bone separates this mastoid antrum from sigmoid sinus, which is a very important relation. Inferiorly, the antrum continues into the air cells, and medially it continues towards the petrous temporal bone. So that means we have the posterior and the lateral semicircular canals and the labyrinth medial to it, and laterally we have squamous temporal bone. Okay, so from all sides there are important relations to this mastoid antrum, and we approach the antrum from the lateral aspect. So we will see how do we approach the antrum, and what are the landmarks that help us approaching the antrum. So the lateral approach to the mastoid is from a triangle that is called McEwen's triangle, and we would be seeing the boundaries of McEwen's triangle. Just to orient ourselves, this is the external acoustic meatus that we are seeing, and we call this margin where my cursor is moving right now as the posterior superior margin of external acoustic meatus. So this is the posterior superior margin of external acoustic meatus. This is the zygomatic arch, and as we zygomatic process or zygomatic process of temporal bone, as we trace it posteriorly, it divides into two roots: the posterior root of zygoma and the anterior root of zygoma. The anterior root of zygoma turns medially, while the posterior root of zygoma continues to move posteriorly. And as we trace it posteriorly, you can see that there is a sort of crest over here. So we start calling it, or we say that it is continuous with the crest that is called supramastoid crest. So the cursor is right now moving on the supramastoid crest, and this forms one boundary of the McEwen's triangle. Another boundary is the posterior superior margin of the external acoustic meatus, and the third boundary is a tangential line drawn along the posterior margin of the external acoustic meatus. So one supramastoid crest, second posterior superior margin of external acoustic meatus, and third a tangential line drawn along the posterior margin. So a triangle is formed, and this triangle overlies the mastoid antrum. A feature that can be seen here is a bony spur arising from the posterior superior margin of the external acoustic meatus is called spine of Henle, and the area posterior superior to the spine of Henle is the region from where we would enter the mastoid antrum. This area is pitted in appearance and is called cribriform area. It is because a lot of emissary veins pass through this area, draining the mastoid antrum. So that's why it is called cribriform area. So this is the McEwen's triangle, and to approach the McEwen's triangle in living, the landmark is this Simba conchi. Now here is the external ear. You are all well aware of the anatomy of external ear. This is the this is the scaphoid fossa, this is the triangular fossa, and just below the triangular fossa, this is the Simba conchi. Or if we go from here, from the concha, which is leading to the external auditory canal, just above that, this is Simba conchi, and through the Simba conchi, we can enter through the McEwen's triangle into the mastoid antrum. It is important that how deep we have to approach the mastoid antrum, and because the lateral wall of mastoid antrum is quite thin at birth, it is just about 2 millimeters in thickness, and the thickness keeps on increasing at the rate of 1 millimeter per year of age till it reaches to its maximum thickness of 12 to 15 millimeters. So that's an approximation that how deep we have to enter to reach the mastoid antrum through the lateral approach. This is a pneumatized portion of mastoid tympanic bone, the mastoid process, and there are so many air cells that are described. The the most prominent is the mastoid antrum that we described just now, and sprouting out from the mastoid antrum, which is actually present at birth of adult size, as we have already said. But the other air cells keep on forming and developing in phases until the pubertal age. And there are different types of antral cells dif- depending on their locations. So there are periantral cells which are located just around the mastoid antrum. Then there are mastoid tip cells, which are further subdivided into superficial and deep cells. Then there are perisinus cells, which are close to the sigmoidal sinus. Then there are perilabyrinthine cells, that means along the medial part of the antrum, or in the petrous temporal around the labyrinth, superior to it, inferior to it, and posterior to the labyrinth. We have labyrinthine cells. Then we have retrofacial cells, because this vertical portion of facial canal descending down along the posterior wall of uh, 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 middle ear cavity, and posterior to that we have air cells. Then we have petrosal cells. Even the tip of petrous temporal may be pneumatized, and when it gets pneumatized, the pneumatization is close to trigeminal ganglion, it is close to the eustachian tube, and it is close and around the internal carotid canal. So even the petrous temporal may get pneumatized. And there are peritubal cells, as we said, that when the petrous gets pneumatized, the tube is very close by, so there will be peritubal cells. And the air cells may extend into the squamous as well as zygomatic parts of the temporal bone. So there may be zygomatic cells and there may be squamous cells. So what is the purpose of having this pneumatization? And we all know that there's an elaborate cell system that is present, and along with that there are very important and big blood vessels flowing close by, especially the internal carotid artery, the internal jugular vein, are very close to this whole system. And together they are considered to form a compound functional unit. And this compound functional unit not just regulates the pressure, but also regulates the temperature of the area, because it is housing an important component which is not just auditory but also vestibular. So so it is said that the whole system, besides regulating pressure, also regulates temperature. And it sort of buffers the vestibular portion from undue changes in pressure and ventilation. It also leads a buffer role. It protects actually uh, the whole acoustic system from fractures and other traumatic injuries by it being a pneumatic bone in nature. So that's why these air cells are important, but probably clinically also very important, as their extent uh, uh, tells us about the spread of diseases as well as the surgical approaches that would be needed. So pneumatization of mastoid, as we said, that it is actually varied, and there are we can have an extensively pneumatized bone, we can have a fairly well pneumatized bone, we can have a poorly pneumatized bone, and we can also have sclerotic bones. Okay, so there can be very many varieties of or very many extent of pneumatization may vary to uh, different extents. Okay, so I think by and large we talked about mastoid process, antrum, and how to approach the antrum, and what is the extent of pneumatization and the air cells that can be present. And now we are moving to middle ear ventilation. And when we talk of middle ear ventilation, there are very many mucosal folds uh, which divide this middle ear cavity into different portions. And to talk about these portions, I've actually chosen because this is a difficult topic to understand and conceptualize. And that's why I have chosen a video which I found was very lucidly explaining the the whole subdivision of the middle ear cavity, and I am playing that video right now. Hello. Just trying to reload it. I think it's taking time in loading.
गुड मॉर्निंग मैम। मैम उसका क्वालिटी हाँ
मैं ये ओके, ये लिंक मैं चैट बॉक्स में शेयर कर लूंगी तो प्रोबेबली आई थिंक ऑल प्रेजेंट वुड बी एबल टू ओपन। कैन आई डू दैट? इज इट?
मैम उसका क्वालिटी जो है सेटिंग्स में,
जी,
इफ दैट वी कैन लोअर डाउन, मे बी इट माइट लोड फास्टर।
ओके ओके। I'm putting the link also in the chat box. Yeah, the link is there. You can open this at your ends. Yeah, yeah. I think because I think the whole of the concept was in this video only, so that's why. Can we do one thing? If Dr. Rajiv's component is not related to this, he can proceed. So that let me check. Dr. Vikas?
Hello. Is it there now?
It's coming,
Which
starts but the volume is low.
Okay, just a minute.
Here you can see the shadow, postal superior, you can see the shadow.
stapes because IS joint
Now?
stapes.
Little better. Can be increased.
Scrotum is nothing
Wait,
but
नहीं है
lateral wall
इसमें.
of the antic area
ठीक है सर.
with the notch of Revenus area.
एक मिनट just. हाँ नहीं, I think it is at the max.
And this scrotum is most commonly damaged in case of cholestoma. So we remove the scrotum, we can enter into the epitympanum, attic area. Attic area is divided by many of the mucosal folds into the different spaces. Here we can see the neck and head of the malleus, and head of the malleus, and it is the incus body. And here you can see the short process of the incus, and this is the posterior incudal ligament, and this incus body, and this is reticular process of the incus. And here we can see IS joint. This is the head of the stapes, and this is anterior crura, and this is posterior crura. Here we can see the footprint of the stapes. Here we can see the stapedial tendon here, and the neck is tensor tympanic tendon. So coming to the mucosal folds, the mucosal folds are head of the malleus. Over the head of the malleus, you can see superior malleolar fold, and in the center we have superior malleolar ligament. Anteriorly to the malleus, we have anterior malleolar fold and anterior malleolar ligament, and this is tensor tympanic fold. And posteriorly, you can see over the incus, there is a superior incudal fold, and over which superior incudal ligament. The central thickened part is ligament, and the total thing is fold. So once we see this lateral, so this is lateral incudal fold, and this is medial incudal fold. In the medial incudal fold, you have two openings between the anterior malleolar fold and medial incudal fold. We have an anterior isthmus, and posteriorly we have posterior isthmus. These are the two isthmuses which connects in fact to epitympanum to mesotympanum. And this medial incudal fold spreads to the stapes and between the pleurals. So all these folds forms a tympanic diaphragm. Coming from this lateral incudal fold, and this lateral malleolar fold, and this anterior malleolar fold, and tensor tympanic fold, and medial incudal fold. This forms something like diaphragm, and this diaphragm is connected with mesotympanum and epitympanum. So only two openings: anterior isthmus and posterior isthmus. So this is anterior malleolar fold and posterior malleolar fold, and these things above which forms the epitympanum. And here we can see there's a Presag space. The space is Presag space, but this is lateral malleolar fold, which usually connects with the notch of Revenus like this. And this Presag space is the most commonly involved in case of cholestoma. And this Presag space is formed by lateral malleolar fold, and medially by the neck of the malleus, and laterally by the lateral process of the malleus, and this is covered with pars flaccidi. The compartments in the middle here, you can see the superior malleolar fold. This superior malleolar fold divides the epitympanum into two spaces. There's anteriorly anterior epitympanic space, and posteriorly posterior epitympanic space. This posterior epitympanic space is once again divided by this superior incudal fold into medial incudal space, and this space is once again divided by lateral incudal fold into superior incudal space and inferior incudal space. This inferior incudal space is continuous with the mesotympanum, and any cholestoma in the posterior region and will collect at the inferior incudal space. And here we can see the Presag space. So here we can understand cholestoma lying in the posterior region. It goes medially into the posterior epitympanic isthmus and enter into the epitympanum. It goes medial to the incus. And if the cholestoma lying posterior region, if it goes through the Presag space and enters into the superior incudal space, it enters into the antrum and it goes to the mastoid region. There are two anterior pouch of Bonthrosh and posterior pouch of Bonthrosh. There is a small gap between the posterior malleolar fold and pars flaccida area. So this area is called posterior pouch of Bonthrosh. When we come to anteriorly, there is anterior malleolar fold, and between pars flaccida there is a space called anterior.
Ma'am, you may please continue now.
Yeah, yeah.
Stop sharing.
Am I audible?
Yes, ma'am.
Yeah. So I think the video, if you couldn't see it properly or download it properly at your own time and pace, you can see the video, because I found this the best resource available, three-dimensionally explaining the various folds. So the concept is primarily that there is a coronal curtain, superior mellular fold, which divides the epitympanoum into anterior and posterior, and there is a horizontal tympanic diaphragm formed by different mucosal folds, which divide the posterior epitympanum into a superior portion and an inferior portion, and medially that portion is communicates via two tympanic uh, openings to the mesotympanum. So that's the thing. And I will, in the next slide, because we had already talked about Prusac space, but since it is so important, so we will just recollect the boundaries of Prusac's space. And this is space, if we can say that it lies just deep to pars flaccida. So its lateral wall is formed by pars flaccida, and the medial wall is formed by the neck of the malleus, and its roof is sort of a tent-shaped roof formed by lateral malleolar fold, and this lateral malleolar fold arises from the neck of the malleus. It fans out and gets attached to the notch of Rivinus. So sort of a tent-shaped space is formed. In the floor of it is lateral process of malleus, and its anterior boundary is formed by anterior malleolar fold. So I think uh, the professor sitting here can elaborate more on the clinical importance of this Prusac space, but these are the boundaries that we discussed about Prusac space. I think we will stop at here, and at your own pace, you can see that video again, showing the mucosal folds of the middle ear cavity. Thank you.
Thank you, thank you. Thanks very much, ma'am. So it was all about the important anatomy, and we all know, as the practicing surgeons, that this part of anatomy is very important to understand, and to it is very important to know that how does the disease progresses in the middle ear and how does it travels, because that is the only way to best sort out the disease from the middle ear and the mastoid antrum and give good and long lasting results. So we'll carry on with the surgical part of this anatomical area, and for that we have Dr. Rajiv with us. Dr. Rajiv will be continuing with the surgical part.
Okay. Good morning to all residents and all faculties. Thank you, Dr. Vikas. I will share my screen now. Can you see my screen? Hello? Visible? Full screen is visible. Okay. So good morning to all. Uh, I will be talking about canal wall up procedures, which has been need to be covered under these headings as suggested by the organizing team: definition and classification, indication, advantage and disadvantages, tips to avoid recurrence, and how to manage complications. So, by definition, what is canal wall up procedure, or we can also call them intact canal wall. So the wall which we are talking about is the external osseous posterior superior canal wall. So the intact canal wall technique basically includes the mastodectomy and the middle ear exploration with removal of disease in contiguous areas, and we have to preserve this osseous external auditory canal. That constitutes the intact canal wall. When we do this surgery, we can combine the surgery with concomitant tympanoplasty with or without ossicle removal or ossicular chain reconstruction. So that is the whole, we say, the surgical part for this intact canal wall. Now, just briefly, the indications, like chronic otitis media, which is persistent drainage and it is refractory to the medical therapy. Second is the cholestoma of the middle ear and mastoid ear cell system. If there is any middle ear tumor involving the ossicular chain and extending into the attic, any persistent middle ear effusion refractory to medical therapy, and facial nerve decompression also in certain post-traumatic cases or even in Bell's, which is not responding to medical therapy. Now, what are the contraindications? The contraindications are extensive cholestoma, which make it difficult for the surgeon to be sure that all the disease has been eradicated. If there is an invasion of labyrinth or cochlea by the cholestoma. One more contraindication is if the canal wall itself is destroyed by the disease. That happens in very extensive disease. So that will be considered as a contraindication for this procedure. A bit about pre-operative, what we have to do before we do the surgery is like evaluation, that is a basic, that we do a audiogram. And because we want to map out the disease, because if the disease is where it is going, so we need to map out the disease. So we should have a very good imaging in the form of high resolution computed tomography of the temporal bone. So we can see where all is the disease gone into the spaces, as ma'am has elaborated all the spaces. And we can plan our surgery accordingly, whether intact canal wall or combined approach tympanoplasty will be suitable for that case or not. Some people would like to give antibiotic therapy so that the coexisting infection will decrease before surgery. I will be briefly telling about the surgical technique also, because most of them are residents, and although they know they are practicing, maybe some are junior, some are senior residents. But canal wall up is not routinely performed. When we are residents, we are mainly talking about the canal wall down, outside in canal wall down mastodectomies in postgraduate course. And slowly as we build up on those things, then we start learning the intact canal wall techniques also. So are you able to see? Hello? Okay, okay. Because I need a bit of feedback in between that all is going well. So this is a standard post-auricular incision, 1 centimeter behind the post-auricular sulcus for all standard cases. But when we go to the pediatric cases, we have to come lateral, as ma'am told that the tip is not well developed, the facial nerve is superficial. So we don't go towards the mastoid tip to avoid injury to the exiting facial nerve from the canal wall, stylomastoid foramen. This is a standard area which we do linear temporalis, and then we go this incision, deepen this incision through the periosteum, and we raise the anterior flap. This anterior flap will be helped in later on when we close the surgical defect. So we have deepened this, cutting through the post-auricular muscle till the periosteum. Now, as ma'am has already told about this McEwan triangle, So this triangle is the landmark for your mastoid antrum, and it is spina Henle is here. So we have to start anterosuperior to spina Henle, because spina Henle is the landmark for external osseous canal, which is we have to preserve in canal wall up. So for all the beginners, the residents, please do not drill out the spine of Henle in the beginning. This is a very important landmark and you must preserve till the end of your surgery, the spine of Henle. So we start drilling. We use a large burr, cutting burr, which should be good cutting burr so that we can drill out maximum. We should drill parallel to the important structures. If we are drilling along the tegmen tympani, it should be parallel. If we are drilling along the external osseous canal, it should be parallel. So we start drilling out in this way to saucerize our mastoid bowl. So this is a simple mastoid bowl which we have to achieve in the beginning. Sometime we can encounter this corner septum, which is a embryological remnant of petrosquamous part, and it is very important to recognize this in the CT itself, because if we miss out this, then we can drill in a different way and we can injure the facial nerve and enter in a different area rather than going into the antrum, mastoid antrum. The another way is to compare whether you have reached the antrum or you are just above the corner septum, is to compare with the annulus of your transcanal annulus also. So that is very important. If you are missing out this, you can land up in a complication. So corner septum, always keep in mind to identify the corner septum, that too on radiology. So once you identify the corner septum, you need to go through it, drill through it, and then you delineate the tegmen parallel, you delineate the lateral sinus, sigmoid sinus, skeletonize these two structures nicely, and try to identify the bulge of the lateral semicircular canal, which will be the, if you see this bulge that you have entered the antrum and this bulge will come. This bone is different from your mastoid bone. This bone is a enchondral bone, which is ivory white, thick bone, and as compared to the surrounding bone, it will be very different looking. So it's very easy to identify, but if there is an inflamed mucosa or sclerotic mastoid, sometimes it may not be difficult in the presence of granulation also. So you have to keep patience and just remove that tissue over that area to identify this lateral canal bulge. So once you identify all the landmarks, then you have to proceed forward. So what you have to identify, you have to thin out your posterior canal wall nicely. You have to identify your canal and labyrinth. You have to delineate your sinodural angle nicely, sigmoid sinus fully, digastric ridge, and posterior fossa plate. This is a whole simple mastoid wall, which is features of a good cortical mastodectomy. Good cortical mastodectomy. These all landmarks should be visible for you in a pneumatized. In a sclerotic mastoid, sometimes it is not feasible to identify the digastric ridge. If you keep on drilling, it will be too much of drilling. So you can avoid that in if it is a very sclerotic mastoid. But these are the important landmarks: tegmen, sinus plate, and your labyrinth and lateral canal bulge. That is very, very important. So once you have identified the landmarks, then you need to proceed forward into the anterior superior direction, where you will see the glimpse of your body of incus and head of the malleus. So anterior superior towards the zygomatic process. This here you have to identify your ossicular chain. This chain you need to identify means you are going through the adductus into the attic. So that is very important. So this dissection, this is a zoom view. Now you can see this is a suspensory ligament, as ma'am was telling, ligaments and mucosal fold. This is a ligament. This is the head of the malleus, and this is the body of incus along with short process. So anterior superior dissection towards the zygomatic process will lead you to the adductus cum attic. All right. Now, how to enter the middle ear when you are doing a canal wall up? When you are doing canal wall down, it is very easy. You remove the bridge and you lower the ridge. So that is the canal wall down. But when you are doing canal wall up, you have to preserve the external osseous canal wall. So there are two approaches. The standard approach, which is used by all of us, is the facial recess approach. This is a triangular area which is bounded by facial nerve vertical segment. Medially, laterally, it is the chorda tympani which is going, and here is the short process of incus, the incus bridge. So this area you need to drill out. So how you will drill out this area, that is important, because in the beginners, when you are beginning this intact canal wall, there is high chance either you will injure the facial nerve here, or you will go into the external auditory canal rather than going into the middle ear. So this is very tricky in the beginners, in the beginning of your career. So you have to keep patience. You have to use the right burr and the right direction. The nature has given us this short process of incus as a landmark, and it is projecting towards that for recess. So you have to drill parallel to this short process of incus. All right. So this is a small study of 51 temporal bones which we did in our department. It was one of my projects, and there is something called a herald cell. So herald means the beginning, and this beginning, this ear cell is present in this facial recess, and it is a gateway for the middle ear. So we did this study, and we found that in 43% of the cases it was seen in a cadaveric temporal bones. So we can see this small herald cells, and when you enlarge a small herald cell, then we can enter into the middle ear. So try to identify this herald cell, and it is just below your tip of short process of incus. Now, once you enlarge this facial recess, then you will enter into the middle ear. You need to see the pyramid, the tendon, the stapes, suprastructure. Now, middle ear explosion means your disease is here around this area. You have to elevate this disease. You have these ossicles now in position. You can see them. You have lateral canal in position. Now you have to slowly elevate the disease from all the areas and remove them. But if the incus or any other ossicle is necrosed, you can remove that simultaneously and do ossicular chain reconstruction. So that is a part of canal combined approach tympanoplasty. Now what are the steps? The first steps is to disarticulate the IS joint. Incus disarticulation is important from the capitulum of the stapes, that you can either do through posterior recess, this recess, or you can also do through transcanal also in the beginning when you do examination under microscope. Once you do this, then you separate the incudomalleolar from here with a right angle pick. This is very easy. Just take a right angle pick and insinuate between the joint and just separate this joint. Separation of joint makes the incus mobile, and you can simply take a right angle pick and mobilize this incus into the mastoid antrum and remove it. So this will remove the part of tympanic diaphragm. As ma'am told, the body of incus and head of the malleus along with the mucosal folds form the tympanic diaphragm, which separates the middle ear from epitympanum. So once you remove this incus, then there is a small bridge which is we initially preserved in when you did the facial recess approach. So you drill out this. This will give you more exposure into the middle ear so that you have a good way to remove, visualize all the disease, all the epithelium, the retraction pocket, so that you can remove that easily. So you have to drill this piece of bone and expose middle ear further. This is to enlarge your posterior tympanotomy. So once you enlarge this posterior tympanotomy, then what is the next step? You have to skeletonize your facial nerve nicely. So why you have to skeletonize your facial nerve? Because you want to see the disease in the oval window area, the sinus tympani, and the facial recess. So to visualize this disease properly, you need to skeletonize the nerve nicely. And there are other adjuncts which I will tell you later on how not to miss the disease in this area. You know, all the resident knows that the most of the disease is left in sinus tympani around the oval window niche. and there from where the residual disease left and need for revision surgery arises. So to clear this disease, you have to lower its skeletonizes nicely so that you can see these nooks and corners of recesses in the middle ear. Now going forward, you have to amputate the head of the malleus. When you amputate this head of malleus, you will open up into the anterior epitympanum. So anterior epitympanum will be seen after this. When you cut this head of malleus, your anterior epitympanum will be accessible. Now, if you want to see hypotympanum, the disease going into the hypotympanum, then you have to cut the chorda tympani. You can sacrifice chorda tympani. This is known as extended posterior tympanotomy. Extended posterior tympanotomy, cut the chorda tympani, then go below and see in the hypotympanic ear cell whether any epithelium is or calcitoma is going there. You can easily remove from that area. And this is after nibbling out cutting out your head of malleus, you can see the anterior epitympanum. This will give you access of the supratubal ear cells, the perigeniculate area, the first genu area, and the supratubal ear cells. So in this way, you have all the access, and you have still preserved the posterior canal wall, the osseous posterior superior external auditory canal. Now, I think this is clear. Hello. This is. So there are few variation to canal wall up technique, which you have told canal wall up procedure. So one of the variation is atticoandrotomy. The disease is limited only to attic and a part of antrum. You don't have to drill out as I told you. So you simply do a cortical defining the tegmen only, and then identifying your antrum and lateral canal and going forward toward the zygomatic process by drilling this area, that is anterior superior area of the zygomatic, this process. So once superior, you will see your incus, and then you have to unfold the ossicular chain in the attic. So taking a blunt instrument, you will remove this epithelium colostoma sac slowly lateral to the ossicles. So this is limited disease. So blunt dissection is done. You have to be very careful not to injure the dehiscent facial nerve or any fenestra in the lateral canal. So this removal of the disease should be blunt and slowly. It should not be very rapidly. Slowly, so it should not tear the epithelium also. So elevating the residual disease is difficult. If you remove en bloc slowly, it will be, all disease will come out in toto. So that is a blunt dissection is needed in this area. One of the another approach of canal wall up procedure is fossa incudis approach. In this way, we can also access the posterior tympanotomy, and it is different from facial recess approach. So what we do in fossa incudis approach is a type of canal wall up procedure. We go transcanal first. We disarticulate the incus stapes. IS joint is disarticulated. Then we have already done the cortical part. We remove the incus, mobilize this incus after separating the IM joint, incudomalleolar joint. Once we remove this, then we start drilling at the level of fossa incudis. That means once you remove the incus, you will see the horizontal part of the facial nerve. From there, you have to trace the nerve. Take a very small bird, 2 mm, 3 mm bird, diamond burr you can take, and there is small bone between the chorda and the facial nerve. You have to follow. The advantage of this technique is that you are following the facial nerve directly from the tympanic segment into the vertical segment. There is less chance of injury as compared to the facial recess approach. So then you skeletonize the whole of the facial nerve nicely by this approach. Now, there is another thing which I need to discuss is what are the advantages and disadvantages of this technique, canal wall up versus canal wall down. I think most of us know that, but it has been told that I have to cover this area. So if you look at the meatus will be normal in up But here we do metoplasty. So why do we do metoplasty? Because we need to inspect the cavity which we make in canal wall down mastodectomy. So we have to have a wide meatus to inspect the cavity. So that's why this look widely open, the meatus, as compared to the normal looking in canal wall up. Now second thing is dependence. So because we have not removed the canal wall, there is no routine cleaning, there is no cavity. But in canal wall down mastodectomy, there is a cavity is there. In that cavity, there will be accumulation of wax and debris over the period of time. So we have to instruct the patient that they have to get it cleaned every 3 to 6 months, or you can say once in a 6 month or twice in a year. Because if they don't clean this area, cavity is not getting cleaned by a doctor, there will be accumulation, debris, and water will go. That can lead to infection and formation of granulation tissue. That will lead to osteitis. Osteitis is then difficult to treat because there will be a breach epithelialized cavity. So once the osteitis starts, then the drainage is little more, and then we have to do again surgical procedure to cavity work need to be done again. So it's better to instruct patient for routine cleaning. Now, because we are doing canal wall up procedure, the rate of residual disease is quite high as compared to the low rate, and you know why? Because when we do canal wall up procedures, the accessibility to the nooks and corners are little less. And I will discuss how to reduce this disease of recurrence or residual disease. Because we are in a that we might have left some disease, there is always a need for second look surgery in canal wall up, but not in canal wall down mastectomy, as we are always inspecting the cavity. So the second look surgery is, some people do within 6 months, some people do after 1 year, and we can do diffusion weighted MRI also if you want to avoid the second look surgery in the beginning. But eventually it is desired by most of the surgeons to have a second look. So limitations. In canal wall up, there is no limitation, there is no cavity, swim, water sports activities allowed. But in canal wall down mastectomy, it is curtailed because of the mastoid bowel cavity. Auditory rehabilitation is very easy because your meatus is normal appearing and the hearing aid is well fitted, as compared to the wide meatus where fitting of hearing aid is a challenging, and because the cavity have wax or debris in time, leading to recurrent infections if it is not cleaned regularly, leading to infection, wetting of the hearing aid also. So these are basic advantage and disadvantages of canal wall up and canal wall down mastodectomies. Now another topic which I need to cover a bit is complications and management. It will be a short thing. So if you are drilling canal wall up like in facial recess approach, you might go and injure the most commonly second genu area. This is the facial nerve which is injured. You can see it is bulging out, is a herniated nerve, edematous nerve, and this is the nerve sheath. So canal wall up, facial research, posterior tympanotomy, injuries. Some surgeons routinely employ facial nerve monitoring, but not all. But still there is a chance for facial nerve trauma. So what we have to do is nothing. We have to just decompress 5 to 6 millimeter on either side of that herniated nerve. And some people love to incise the sheath also, so that the edema will settle. Or if there is a hematoma, that will also settle. So very simple, decompress on either side. How much to decompress? So we can decompress at the maximum of 180 to 270 degree in this area, and 5 to 6 millimeter on either side of exposed nerve. Another complication which occur is canal fistula. Lateral canal bulge we have seen, but in the beginners, when the beginners are doing, there is an inflamed mucosa over here and they are drilling. They are not identifying it properly. They are drilling, thinking it is an antrum, and they open up the lateral canal. So if inadvertently, if somebody opens up the canal, what we have to do is immediately use bone wax and seal it with duckbill handle, duckbill instrument, plug it, and then take a temporalis fascia and cover it nicely. So that is a very simple to seal it. So when you have opened up the canal, and don't suck on the opening, don't suck on the opening, instead fill that area with a physiological saline. We don't have to make a dry canal, don't suck out the perilymph, just cover it with physiological saline and then use bone wax, seal it immediately, and in the end you remove the put the temporalis fascia over that. Sometime you have seen when in the beginning some people are drilling over the sinus plate, they injure the breach the sinus plate and injure the sigmoid sinus. There can be a vascular injury. Nothing to panic. Just cover it with Surgicel and put a cottonide and keep a pressure for 10 to 15 minutes. Most of the time it settles if it is a small injury. But if it is a large injury, then sometimes you have to take sutures. If it is a large tear and there is a lot of bleeding, the Fogarty catheters can be put on either side down, which will occlude the flow, and you can take a 4O suture and do a continuous suturing. That is one of the techniques if there is a large tear, large area is torn by the burr. Another option available is just use a muscle plug. You can take a temporalis muscle, plug it, and then you have to suture it so that the muscle plug should not migrate. So there are these two techniques to manage this, but most of the time it is managed simply with Surgicel and cottonide. If you are exploring the hypotympanum area, sometimes there is a high jugular bulb which is dehiscent, can lead to bleeding into the hypotympanic air cells. You have to simply use bone wax, fill that cells with bone wax and use a cottonide to rub so that it should nicely fit in all the hypotympanic air cells and to stop the bleeding. Whenever there is a bleeding from the sigmoid sinus, one thing we need to remember here is if there is a bleeding which is profuse, then it can lead to air embolism also. So you have to use the reverse Tendelbung position and inform the anesthesia people chance for air embolism for vascular injury. So this is a small video for intact canal wall facial nerve decompression. It is done by one of our colleagues, Dr. Prem. I have taken from her. So it just shows a closed tympanoplasty facial nerve decompression. Very short video. There is a grade 6 paralysis, and this is the fracture line you can see going around with the soft tissue density in the area of first genu. This is his audiogram. The TM is intact. So you start in the post, as I told you in the schematic diagram, McEwan triangle, start drilling nicely, saucerize the cavity. Because there is no disease, the air cell will be mostly pneumatized. So immediately you will enter into the antrum. And then this is the anterior superior direction, zygomatic process. Towards the zygomatic process, you will see this drilling. So here you can see the glimpse of the outward, you will see the short process of the incus. Now this is facial recess approach. You have to see this is the short process of incus, and here will be your Herald cell in this area. You have to follow this with a diamond drill nicely and see the opening which is going into the middle ear, and then you have to enlarge this opening slowly. You have to don't be in hurry when you're doing this approach, because that will lead to only injury to the facial nerve. So now you have entered into the middle ear, you can see the tendon. All right, now you have to just decompress your facial nerve at the second genu and the first genu, because it is seen in the CT that the area of injury in this fracture is between first and second genu, the horizontal segment. You have to go now slowly in this area and decompress the nerve with a diamond burr. So in this case, the ossicles were left intact because the hearing was normal. So ossicles were not removed. The incus was not removed. The malleus head was not removed. It was intact canal wall. This is a fracture segment which is being removed over the tympanic segment. So there is no disease. This is post-traumatic facial nerve decompression. So in the disease chronic otitis media, you might need to remove the incus and the malleus head to access the anterior epitympanum. Here it is done for facial nerve decompression. So, and hearing was normal, that's why no ossicle was. You have to be very careful because the trauma from the drilling can lead to SN loss. So very gently, under vision and small burr need to be used to decompress the nerve nicely. So you can see the glimpse of nerve. This nerve, this is the indicator for your nerve, and then it is slowly, the bony shell is flaked out from the tympanic segment and the second genu area. So this whole nerve is now fully exposed, and this is the incus which is in position, and this is the tendon with the IS joint. You can see this is flaking out. This is known as flaking out of the eggshell. When you thin out eggshell, then in the end you have to just flake it out, the bony segments. So here only you have a risk of doing lateral canal fenestration when you are doing. So I have already told you, if you open up the lateral canal, what to do. That would be easy. Use a bone wax and then temporalis fascia. So it's not, I would say it's not very easy. It's an edited video, but it needs a lot of practice on temporal bones to do with ossicles intact and intact canal wall. So slowly and slowly, as you gain experience, it becomes easier and easier for you to understand. And you should have a good quality burrs when you are doing temporal bone dissection. Now you can see this, the facial nerve, the ossicles nicely seen. This is the ossicle, this is the facial nerve going down towards the first genu. Now you can see complete eye closure, and there is a movement, nasolabial fold is forming, and the hearing is normal. There is no SN loss component. This is done by Dr. Prem, faculty in our department. So last part, tips to avoid residual disease. So when you skeletonize the facial nerve nicely, you access these areas, oval window, sinus tympani, and facial recess. So there will be less chance of leaving residual disease in this area. These are the common residual disease in posterior part of your middle ear. You can use autoendoscopes, which are available now in most of the institutes, to look into the nooks and corners. Initially there were Buckingham mirror, but now I think autoendoscope have replaced all mirrors. And the anterior epitympanum, you will, once you remove the head of the malleus, you will gain access to the supratubal cells and perigeniculate area to remove all the disease. So that's all. I would like you all to come to the NESCON, which AIIMS Delhi is organizing, and you can participate in various categories. The abstract submission is open and it's till 30th June. So thank you so much for giving me this time.
Thank you, Dr. Ajib, Dr. Sunita. Very, I think, useful for all the attendees. And with this, we started with the ear surgery per se, the most commonly done ear surgeries. So next time we'll be covering the most dreaded, most read part of the ear anatomy, that is the facial nerve. That will be the part of anatomy, and accordingly we'll be having Dr. Manoj Manikot for this will be covered by anatomy will be covered by Dr. Motasim and Dr. Manoj Manikot from Calicut. He'll be showing us the various surgical steps of canal wall down, and will try to take the fear out of facial nerve. So thank you very much. So now if we have any queries or questions, we may please, delegates may unmute them and themselves and can ask.
हेलो।
Hello, हाँ राहुल।
हाँ सर, गुड मॉर्निंग सर। सर मैं ये पूछना निकाल देते हैं सर तभी।
Yes.
देन हाउ डू वी मतलब निकाल वापस डू वी प्लेस देम बैक और वी
Yeah, yes, Rahul. We can, as I told you, it involves ossicular chain reconstruction also. If your ossicle is not involved by the colostoma, if it is eroded by the colostoma, we tend to avoid it. But if your ossicle is absolutely normal, we can refashion it, and we can do, if your stapes head is available, then you can do interposition with your stapes head and malleus handle. You have to have a ossicular chain holder with you and a very small 1 mm burr, and you have to just make a slot for your stapes head and a small longitudinal groove for your malleus handle. You can interposition there. If your ossicles are necrosed by the disease, then you can use TORP or PORP. If that is not available, you can use cartilage graft. So always you can do ossicular reconstruction, but I would say if you have to calculate your middle ear risk index, MARI, because if your disease middle ear is inflamed, there is lot of granulation tissue when you operate on these kind of cases, then I would say that you should wait for 6 months, put a elastic promontory to station tube, let the middle ear aerate well, and do second stage ossicular reconstruction. But if your middle ear risk index is low, then you can go ahead and do ossicular chain reconstruction in the same setting. But you should be sure that you have removed all the disease.
Okay, sir. And what about the head of the malleus part, sir? You said that we have to cut off the head of the malleus in
Yes.
order to. Do we need to address that also?
With regard to?
Like the head of the malleus, sir.
So head of the malleus is removed so that you can move forward to anterior epitympanum. So you can preserve that ossicle. If you want to reuse that, you can use that, but mostly we use incus interposition, because that is a little big ossicle and it is able to connect to handle of malleus and the CP superstructure.
No, sir, my doubt was whether we need to put the head of the malleus back there or we can keep that.
No, Rahul, we don't have to. We have amputated the head of malleus. We don't need to put it back.
See, head is removed when the incus is already diseased. So these are the cases. So you have removed the incus and now the head is there, and you have a doubt or you have disease medial to the head of malleus. Medial to the head of malleus. And the disease is medial to the head of malleus, there is chance that disease is anterior to the head of malleus also. So you remove the head. So it doesn't see, the purpose of head is to act as a joint for incus. So if incus is gone, head is, there is no purpose of head being there,
Okay, sir.
because your head will still be stable. Your handle of malleus will be stable because it is there
Tendon
with
is
the
there.
tensor tympani.
Yes, sir.
And then there
Yes,
would
sir.
be anterior and posterior malleolar folds also, which will be holding it back. For stability, you do not need it actually.
Yes, sir.
Hello, sir. My question to Dr. Rajesh, sir, it's a really nice talk. It
Thanks,
presents our
Anand.
old stuffs and also adds extra thing to it. If you are doing a articutomy
Yes.
and at the same time you are preserving the posterior canal wall, to what
Yes.
extent you are doing the articutomy? To what extent, suppose that you are removing the incus
Yes.
and also drill so much in the artic, and how you reconstruct it, and if you reconstruct the artic, then what ossicoplasty you are doing in that case?
So, Anjan, how much to remove will depend upon your extent of disease. Basically, you are following the disease.
Sir,
Once,
suppose we are removing a large part of artic, so you are converting it to a canal down, or you still preserve the
so as
canal
I
wall?
told you in the variation of this technique, the eticoenterotomy is also by toss. If you go by the toss
Sir,
perforation, they say it is canal wall down.
Down.
But if you go by other books, they say it is canal wall up because you have
up.
not removed the osseous external wall completely. You have not created a mastoid cavity. You have just
Sir.
followed the disease from attic to antrum. So if your disease is completely removed, then you can use, if your incus is gone, you can simply do torque if your stapes head is present. Head is not present, you can use torque. And to reconstruct, you can use this concha. You take a semilunar cartilage and in the shape of lateral attic wall and just place it nicely, replacing the sputum. Basically, you are drilling the sputum, the lateral attic wall
Sir.
to uncap the attic. And then you see the ossicles. If the disease is medial to ossicles, you have to remove the ossicles and then you reconstruct with the cartilage. That's how we do it in this case.
Sir, largest studies say that if you are reconstructing a large part of the attic, then
Yeah,
in long run that portion falls off. So
that
there is
portion.
chance of that portion doesn't stay there.
So that's why I'm
Suppose you
saying
are
it should be well fitted cartilage.
okay.
Because if you use a small piece of cartilage, you have anterior and posterior arch. The semilunar cartilage should fit in that area nicely. Then only your lateral attic wall will reconstitute it. Otherwise, it will fall down. So
Then
well
you
fitted
can
Okay, sir.
cartilage.
you can cover the cartilage with the periosteum sheet.
Graft. So we have to
So
graft it later on after putting the cartilage.
Thank you, sir. Thank you, Dr. Vikas. Thank you, sir.
Any other question?
One
Hi Pooja, how are you?
good.
Nice to see you.
I want to ask, we are over the.
Your voice is not clear, Pooja.
Hello,
Yeah,
can you hear me, sir?
yeah.
Sir, I wanted to ask, when we put a graft over an iatrogenically damaged lateral semicircular canal,
Yeah.
should we put the other graft, the one which we will use at the end, should we put it over that graft?
No, like you damage the canal immediately, in canal wall up, I am saying. It is not damaged by the disease, it is damaged. Your question is you have
Yes,
damaged
sir.
it, not
Yes,
the
sir.
disease.
Yes, sir.
That is different, this is different. Now, if you are doing canal wall up and you have damaged the canal opening, you have opened it somewhere, immediately first you put physiological saline so that they should be not drying up. Then take a bone wax and a duckbill and just paste it over that, and then use a small piece of temporalis fascia to cover that. Later on, when you graft your full other layer of the temporalis fascia over that.
Yes, that's what I want. Thank you, sir.
Okay. Any other question from resident? Canal wala, you have to do lot of temporal bone dissections, and you will definitely learn it as you do more, because it's really a challenging surgery. It's not that easy because of the limited area of drilling, and you have
Hello, sir.
ossicles, you have fascia nerve there. Yes, Nitin.
Yeah, good morning, sir.
Good morning.
So my question is, for example, if we suspect the patient has a eustachian tube dysfunction,
Okay.
and in such scenario, I have seen that there's recurrence of disease. I mean, we have grafted it well, and after a few months, like 6 months or after maybe a year, the
Yeah.
patient again present with the discharging ear.
Yes.
How can we manage such cases? Should we, if we go for surgery? I mean, if we suspect that the eustachian tube dysfunction is present, and how do we suspect that? For example, is this, for example, a patient is having perforation in both the ears, subcortical, and he's not having any sort of nasal discharge or had a history of any nasal allergies. Uh, so probably this patient is having eustachian tube dysfunction. So how do we proceed with this patient? Because I have seen that practically that the patient who have bilateral perforations,
Yeah.
when we graft 1 year, and they usually present back. They usually have, maybe after some years, few years, but usually they come after.
So Nitin, what I told you, as you said, you have done the nasal workup. You have looked
Yeah.
your nasal
Yes, sir.
allergy. You have done endoscopy. There is
Yes,
no
sir. Yes, sir.
sinusitis component to that, no adenoids, and then
Yes,
you
sir.
grafted. So
Mhm.
there is a recurrence of disease. So what I would suggest in that case is that you do cortical and you try to look for try to remove the adductus. There is a mucosal blockage in the adductus, which
Okay,
prevents
sir.
the ventilation. So I would say if there is a revision case whenever come to you, or you want the success to be 100%, you can combine cortical mastodectomy with tympanoplasty. Because most of the failure, if there is no revision in the sinonasal area, no cause, then it is the mucosal fold edema which lead to
Mhm.
ventilation failure. So to
Sir,
prevent
you
that,
says eustachian tube dysfunction. So can we do anything for eustachian tube in such a case?
yeah,
I mean,
balloon station to plasty is available these days.
okay, okay,
Balloon
all right.
Q1 plastic is available. It is marketed by one very good company, and it is very coming up in many centers. They are using this balloon catheter. They
Okay.
inflate that, and then they open
I'm,
the.
I'm not very much aware of this. I mean, they go through nasal route or
Yes,
during
they
the
go through
nasal
nasal
route?
route only.
Okay, 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 right,
It's
right.
available. It's like just sinus balloon plastic. It is now
Yes,
station
sir.
balloon plastic is available. So they
Yes, sir.
insunate through the under endoscopic guidance,
Okay, sir.
nasal endoscopy, and then they inflate and keep it for maybe 15 to 20 minutes, and then take it out. So to open up, to make a micro cracks in the cartilaginous part of the eustachian tube.
Okay, sir. Mhm.
So that is
Right, right.
available now in market also.
Okay, right, right. Thank
Yes.
you, sir. Thank you.
Any other question from any residents?
Dr. Utkal,
Yeah. Thank you.
thank you.
Very
Thank
nice
you, ma'am.
talking to all of you.
Thank you, ma'am. Dr. Sunita.
Thank you, ma'am.
Most welcome, most welcome. And it was, I think I would just like to add that we usually, because the system is such that we are not much in contact with clinicians, and adding up anatomy component, we had so much to learn, because with now endoscopic view, the anatomy, the traditional gross anatomy that we used to talk has so many new things to add to with that focus. So it was a learning experience for me as well.
Yes, ma'am. We are also looking forward to exploring this concept to all the at least ENT head and neck areas.
Yes.
So, Thank you very much, everyone. See you
Thank
next
you.
week.
Thank you, ma'am. Thank you, sir.
Thank you.
Bye, Dr. Vikas.
Bye.
Yeah.
Bye, Anjan.